Join Raise the Line in celebrating the launch of the new Osmosis Clinical Sciences Library. Developed for first-time clinical learners, it includes hundreds of visually engaging videos paired with decision-making trees aligned to U.S. core clerkship curriculum guidelines to help students think clinically from day one to patient one. Start your free trial today at osms.it/rtl.
Hi, everybody. I'm Michael Carrese, welcoming you to Raise the Line with Osmosis from Elsevier, an ongoing exploration about how to improve health and healthcare. One silver lining of the COVID-19 pandemic is a jump in enrollments in public health degree programs at both the bachelor's and master's levels. In fact, applications to graduate-level public health programs across the country grew about 40% during the pandemic. According to a study out last year by the Association of Schools and Programs of Public Health, one factor driving that surge is a newfound awareness among young people of the systemic health disparities that impact their communities, and that public health is a field focused on structural reasons for health. To learn more about the field in general and master's degree programs in public health specifically, we're joined today by Dr. Jan K. Carney, a leading figure in Vermont's medical and academic community with a significant national footprint as well. Dr. Carney is Associate Dean for Public Health and Health Policy and Director of the Master of Public Health program at the University of Vermont's Larner College of Medicine. She served as the state's Commissioner of Health for 14 years, during which she highlighted children's health insurance, teen smoking, and cancer screening, among other issues. Nationally, Dr. Carney is a member of the Board of Regents of the American College of Physicians, which is the largest medical specialty organization and second largest physician group in the United States. And thanks so much for being with us today.
Thank you for inviting me.
So we always like to start with learning more about our guests and what first got them interested in medicine, and then, of course, in your case, also public health.
Well, all right then. My interest in medicine started when I was in elementary school. I had a teacher whose husband was a medical intern at that time, and so she would tell us about all the medical adventures she was hearing about in her life, and I became very interested. I remember specifically learning about and hearing about all aspects of science. And so I became extremely interested in science and medicine and decided and told my mother that I was going to be a doctor when I got older. My father was a dentist, and he often, part of his practice that he had for about 40 years was making people feel better and relieving their pain. And so I think a combination of a love of science, and that later grew into understanding more about medicine and healthcare, and just basically wanted to help people. And like many people start out going into the profession, but that's where I started and kept going.
And when did you decide to take the academic route and then further getting into leadership in an academic setting?
So I didn't discover public health actually till I was all the way through 4 years of medical school. I did 4 years of internal medicine residency, 3 years, and then I was the chief resident my final year. And so I'm an internal medicine specialist. And then I was seeing patients and ended up at a medical conference, and there was something about preventive medicine and public health, and I was, what's all this? And one thing led to another, and then I ended up going to public health school and getting a master in public health. And that was, for me, the aha moment of my career. And I love medicine, and I loved working with patients. But what I discovered was there was this whole other science that I really had no clue about that could prevent disease and illness in entire populations. And it was a little bit of who knew, and why haven't I learned about this yet? And so I delved right in, got my master's degree, came back to Vermont, and was determined to look for any opportunities in public health. And right pretty soon after that, about a year after, I became the deputy health commissioner, then a year following, the commissioner of health for the state, where I worked for 3 different Vermont governors, both Democratic and Republican, and just had the amazing experience and opportunity and awesome responsibility for public health in this wonderful state. So that's how I ended up there. And at the end of that time, I'd always been, I think that when you're, I don't know, I think a lot of physicians, or nearly all physicians, think of themselves as we're teachers. We might teach people one at a time. We might teach students in a classroom or in a small group, but I was always on the faculty teaching even when I was a state health commissioner. And then in 2003, I came back to UVM, to the College of Medicine full-time, and then started my work to bring graduate public health education more to our medical students, and then graduate public health education as its own discipline here to the university.
So at the beginning of your career, was it unusual for an academic medical center and College of Medicine to have public health programs?
If you were in medical education, you really didn't, it just wasn't a big part of medical education when I was in medical school. And I think that's changed. That's changing rapidly now, and has changed in the past 10, 20 years. And part of it is you think about the evolution of our health systems, right? It used to be we'd have people in solo practice or independent practice. My father was a dentist, and he was all by himself in his office for 40 years. But that's changed. And now we had larger physician groups, and now you have more health systems that might have hospitals and lots of physicians and nurses, and it's really, healthcare is more of a team sport, I would say, than it used to be. And also some of the configurations cover geographic areas. The accountable care organizations, the large academic health networks might encompass smaller hospitals and lots of physician practices across a broader geographic area. So all that lends itself to, when we talk about public health and population health, sometimes it refers to population health management is how do you take advantage of a large number of patients in a geographic area and leverage both higher quality care, also preventive medicine and better preventive care. And so if you think about that on a practical level, electronic health records, or you can look and see what percentage of your patients has an annual flu shot or has their pneumonia vaccine, and certainly for childhood vaccines, things like that. So I would say there's more, our systems have changed. That's one factor in terms of thinking about the population. And also many of the issues that we have now, I would say public health issues, they just really intersect medicine and public health. And I feel like many days I have one foot in public health and the other foot in medicine, and they're all connected. You can think about many such issues like that we're dealing with today.
Yeah, well, right. Beyond the pandemic, you've got chronic conditions like diabetes and asthma, all the environmental issues. So, yeah, that makes sense. That's a nice big picture look at the whole thing. So what's your elevator pitch, as they say, when you're talking to young people who might be interested in pursuing a career in public health and also getting an advanced degree?
Public health has never been more important. And we just are hopefully on the backside of that global pandemic, but that doesn't mean there might not be something else just right around the corner. And some of the things that the negatives and the terrible things that we learned in the pandemic was that our public health systems need a lot more strengthening. And people talk about cycles of panic and neglect, right? It's really hard to be, and that's human nature. It's really hard to be prepared when nothing's happening. You go, well, nothing's going to happen, so we'll just kind of coast along, and then something happens, and you may not be ready. We can't afford to do that. The consequences are just too great. We saw in our own country, in addition to the a horrendous impact in terms of illness, death, long COVID, just horrible situations for patients and families and communities that access to healthcare is not universal in our country and remains very uneven, and health remains determined by zip code. And I think we also saw that our history of systemic racism and vast health inequities were also greatly magnified during the pandemic in many individuals and communities and populations. That was, that was the dark side. Was there anything positive? Well, we learned that we can use telehealth, so let's keep using it. And think about a rural state like Vermont. And I work with a lot of colleagues in northern New England and New Hampshire and Maine, and I did a lot of work during the pandemic with United Way and our United Way organizations to try and determine what were the worst priorities and what could we do to help. And so access to healthcare, at one point we were all shut down, but then access to mental health services, access to substance abuse treatment, access to healthcare for rural populations is always challenging, was even more challenging. And telehealth, and our medical students did a project on this to talk to both health professionals and patients, and everyone thought very highly of telehealth. So think about how can we continue to use this to help make healthcare more accessible to more people. For us, sometimes it's the travel in the winter roads or the mud in the spring, but it's also transportation in rural areas. It's also making it more just accessible or easier for more people in more communities to get counseling or substance use treatment. It gives you another option. So I'm hopeful that we can remember that and keep expanding that in the areas where that makes sense. Another area I just mentioned is that I continue to marvel at how fast they were able to develop vaccines related to COVID. And we just saw another RSV just come out, and so vaccine development, really, that was phenomenal. And then on the public health side, getting those out to people. And I understand that not everyone is in total agreement about our need for all these and those sort of political controversies, I'll call them. Those remain. It was just an amazing scientific feat that just helped so many people. So, that was a really good thing. The other thing that happened, which was unfortunate and made me very sad, was in some locations here in Vermont, I think that the teamwork and the collaboration between our Department of Health and people in healthcare and the university and our community organizations was just, it couldn't have been better. And I really attribute how well we actually did, despite all the illness that we saw and all the terrible consequences for many people. We gave it our best. And I was really very proud of how we did that. In many areas of the state, that wasn't the case, and of the country, that was not the case. And in some places, people who worked in public health just were almost vilified, but really not appreciated in any way. I think that big picture here is that organizations like the Vermont Foundation published a report in 2021 that said, sort of over the last decade before that the number of full-time personnel in public health, local state health departments, public health agencies across the country had declined by about 15%. And based on their projections, working with some others, that we really need probably an 80% increase, 80,000 more people working in public health, maybe 2/3 of those in local health departments, maybe 1/3 of those in state health departments, to have the basic essentials of public health. So we have a huge workforce need. That's what public health has never been more important. The issues are so challenging, and we could, if we can talk a little bit about the kinds of education you get in public health that helps you address that.
Yeah, I did want to get to that issue. I mean, you talked about telehealth increasing access to healthcare, but online learning also has increased access to education. And you've got an online program there at Larner. So why don't you tell us about the program, what you think differentiates it?
We started in about 2011 developing the program. When I came here from my previous work at the Department of Health, everyone started asking me, when are we going to have an MPH program? And we didn't have one. And so people working in public health who aspired to work in public health, or clinicians who wanted to learn those skills, you had to actually go someplace. So we talked to a number of people. I worked in partnership with UVM's continuing distance education. They were just absolutely fabulous, and the graduate college. And so we talked to students and people who wanted the education, and we made a strategic decision to develop an asynchronous online program. Everything was going to be asynchronous online. This was way before the pandemic, before everybody went, oh my goodness, we have to do this online. So what came out of that was, in order to do that, you had to have a platform to do that. And then you had to start thinking about, how do you do active learning? Because we sort of have, in medical education, certainly, and in most kinds of education, moved away from the stand and lecture and people are doing something else with their computer screen, to something that's way more active and engaging. And so we had to think about, how do we do that in an online environment that you could be on everyone at the same time, but you don't have to be. And so we started to experiment with some innovative discussion platforms, and we use those, and students really like them. And the concept of a lecture is, you should not see one longer than 15 minutes. And there's pre-learning and short video instructor videos and quizzes to assess your readiness, and lots of sort of smaller chunks of learning and assessment to keep building your fund of knowledge and your skill set or your competencies in these different domains of public health. I think that the team that we've assembled here, we have instructional designers who are just amazing. Our faculty are amazing. Our faculty are both full-time faculty, and we have part-time faculty who work in very broad domains of public health, like the Department of Health, or like in environmental public health or epidemiology. I have two public health veterinarians who help us with One Health and zoonotic diseases, and think about, let's not think about our next pandemic, but in these different domains. So there's epidemiology and biostatistics. You have to learn the math. And then there's environmental public health. Think about climate change and all about that. We have social and behavioral determinants of health. So think about our habits and behaviors, and how in healthcare, we think about influencing those one at a time. In public health, we step back and say, what are the practices, policies, programs? What can we do to influence, for example, tobacco use? A good example of that would be, if you hike the price of cigarettes, it's like a brick wall in front of young people who are just experimenting with them. So in all likelihood, they won't. All right. So think of a variety of strategies, but alcohol falls into that category. Certainly all addictions and opioid addiction. And also think about the habits and behaviors we're trying to promote, like people having enough food and access to healthy food, and also being physically active, which these are the predictors of longevity in our population too. So habits and behaviors. And then we, of course, learn about our public health systems and our healthcare systems and how we relate. So there's 5 broad domains. And then that's sort of very traditional. But then if you think about today's practice, one of the ones that just cuts across that, we have things like advocacy, but communication. So think about how people get information, but think about all the misinformation that we just have been experiencing. And so in public health, learning to be excellent communicators, whether that's in writing or to a group or to individuals. And then on a population level, what are some of those strategies we can use to try and counter some of that misinformation that unfortunately is out there? So I'll stop there, but those are kind of the broad areas of public health.
Yeah, it's a lot. And that's what makes it a kind of an appealing career choice, because you can go in all of those different directions, and each one of them is incredibly important. Vermont is a very rural state. You touched on that before. What do you do to help prepare folks to operate in that environment with all of its challenges?
As you asked that question, some of our medical students did a project last spring and worked with a community organization, Windham County, to try and healthcare access is a huge issue in the rural areas. And so they asked the question from medical students and nursing students, what is it? What is it that might attract you to a rural location? And the answer that we got was having experience in a rural location. So we have to give, whether in healthcare or public health, people that experience, because I think that you can't just read about it or study about it or learn about it in the abstract, that you have to be able to experience and problem solve. How do you know about the health of that community, and what are the different factors from those different domains that we just talked about? How can I make a difference here? In public health, I think about sometimes connectors. So as an example, community health workers who are not necessarily doctors or nurses or formally trained in healthcare to that intensity can connect people in communities to things like cancer screening, health education, preventive services, all kinds of things. That might be a public health kind of approach to doing that. Another thing I might mention, and which is a focus of my research right now, is around health communication and health literacy, health communication. But here's the idea: is think about how we all got information or tried to get information during the pandemic, and it was coming at us, and it came from government agencies and health departments. It might have come from the news, the media or social media. It might come from the hospital or academic health center. It might come from university faculty, on and on. But when I think about that, I think it's one way. It's one direction. It's from us to you. So my question was, how do we know that that's the right way to communicate, or that people want to receive that important and potentially life-saving health information in that way? So one of the things we did when we worked with the United Way about 6 months into the pandemic, and we did an electronic survey. We asked people about how they, first of all, was there enough health information reaching them? And of course there wasn't, particularly in the rural areas. But also, were there differences if you were in a rural area of Vermont, or if you were in I use the term loosely, urban center in Burlington? And the answer was yes. People in Burlington and Chittenden County wanted to receive health information through the internet, and Front Porch Forum, our networking platform, And people in the rural parts of our state still like word of mouth, but really like their town papers and Facebook. And these were all, yes, and they reached statistical significance. And so we were like, maybe we should think about this a little bit differently. If you're getting that important evidence-based, scientific, medical, and health information out to the public, maybe we should start to make sure that we're sending it in the way they want it, and that we can start to think about more like two-way communication. More you think about a conversation as opposed to kind of one-way information flow. So we're trying to do that now in one of the grants that I'm working on. And we're working with some older Vermonters in support and services at home, SASH program, specifically around COVID vaccines and the booster shots, and just asking, what do you want to know more about this area? And then how would you like us to present that or offer that to you? And what they've been telling us is, we want a one pager. We want it to be fun and have cartoons. We want it to be from reputable sources like our health department or the CDC. And we want the font to be big enough. I'm like, okay.
Yeah,
well,
this is great.
Well, so here it is. And so we're sort of in the process of, we've been pilot testing that idea, and we're about ready to offer that same information to some more people to further refine that. But that's the concept anyway. And it might look different for different places, and rural versus not, versus depending on, where you live and maybe what your age is. But the idea of perhaps that we could cut through some of this misinformation if we started to think about presenting our science and health information in a way that people want.
Yeah. Know your audience, right?
Right.
So it just seems like communication science is really becoming integral to the science of medicine and public health.
Yeah.
It's kind of unavoidable. We just have a couple minutes left. We always like to end with having our guests provide their go-to advice for an audience of learners, particularly how to meet some of these huge challenges at this moment. What's your advice for folks navigating through all of that?
If you're a student and any of this that we've been talking about interests you, find out more. And, you can go to our website and you can learn about the kind of content and where that leads you. Everyone now, the good news is everyone knows what an epidemiologist is. And there's lots of opportunities. And the science and practice of public health is extremely important. It's also very practical. So, learn more about it if you might be interested. And what we have here and what is available is students or anybody can take a course, not as a degree student, and try it out. We are in the process of, and we hope we'll have them offered by the first of the year, of these 3 course packages of areas of public health that are called micro certificates of graduate study, so that you can learn a chunk of public health and see if that's something that is right for you or might complement, for example, if you're a nurse or if you're in medical school, if these are the kinds of things that might help you broaden your view of the world to include populations and might resonate with you.
Yeah, that's interesting. Stackable credentials has become a trend as well.
That's right.
So a lot of options, a lot of flexibility. And if folks wanted to learn more, they can go to www.med.uvm.edu/public health. With that, Dr. Carney, I want to thank you very much for taking the time to join us today, and also for all the work you have done throughout your career and you're doing now to support public health. We really appreciate your time.
Thank you very much for inviting me.
I'm Michael Carrese. Thanks for checking out today's show. And as always, remember to do your part to raise the line and strengthen the healthcare system. We're all in this together.
If you like this podcast, please share it on your social channels. You can also subscribe to the series and check out all of our episodes at osmosis.org/raisethelinepodcast.